Hey guys, it's Christopher again, your friendly neighborhood paramedic, and today we're going to be talking about electrocardiograms. So, oftentimes you're probably seen on TV shows, or maybe you've even been to the emergency department with family, friends, or even been a patient yourself, and you had to have an EKG done. And you're going, what does all those squiggly lines mean? Well, I'm going to kind of go over a few of them and hopefully give you a little more information about what an EKG is and why we use it so much in the ER. So one of the big things is the electrocardiogram shows us about the electrical activity in the heart. So the first rhythm I'm going to show you is the one that's on the screen right now, which is normal sinus rhythm, also known as sinus rhythm. And normally, your heart, all right, on a good day, will be at a rate between 60 to 100, all right? And when we have this, we have a rhythm known as sinus rhythm. All right, and so sinus rhythm means that everything is functioning inside of the heart electrically the way it's supposed to. It's the right rate. Everything's working correctly within it, and this is normal. Now the heart can go just a little bit slower. All right, and so this rhythm is known as bradycardia, and bradycardia is a rate of less than 60, and you can see how it slows down. We can see that the rhythm slows down. We have a heart rate of 41 that's showing right there. So bradycardia can be a normal finding in patients who are maybe athletic, all right? But if a patient has symptoms of bradycardia, let's say we have a patient who comes in with chest pain, shortness of breath, weakness, those kind of things, and they're bradycardic, we may have to give them medications in order to get their heart rate up. And if it gets severe enough, we may have to take over the pacing of the heart, which is normally done at the SA node. If it's not being paced fast enough, we may have to actually do an external pacing, and I'll show you that in just a second. Now, heart rates that are greater than 100, all right, that are regular, are known as sinus tachycardia. And so sinus tachycardia is going to be a rate greater than 100, so you can see the heart starting to speed up there just a little bit. There's a PVC on there, so you give it just a second to start doing its thing. Now we're going to start seeing the heart rate start to speed up, and it's going to be greater than 100. So let's watch it. It starts getting faster. It's at a rate of 121. So guys like me who are out of shape, sometimes if I go up the stairs, I may get a little bit of tachycardia. But we can also see tachycardia as a normal finding when we have somebody who has a fever, for example. All right, and other different things. Sinus tachycardia, so it's a rate greater than 100, all the way up to 150. Now, if the rate is greater than 150, and we see the following rhythm. We see this one is 216, 217, and so this one, we're seeing runs of what's known as supraventricular tachycardia, and it's giving me an alarm because it's witnessing that. So SVT, as you're seeing, is really, really fast, and so what's happening there is the normal pacemaking functions that happen at the SA node are being basically paced by ectopics in the heart, and so we have supraventricular tachycardia. Now these patients will exhibit things like chest pain, shortness of breath, they're going to have palpitations and everything, and so we can generally get this to convert by getting the patient to bear down like they're having a bowel movement, which is known as a Valsalva maneuver. We can give them medications like adenosine, which actually kind of restarts the heart, and if that doesn't work, we can always cardiovert is where we do electrical activity to basically kind of shut down the heart for a second and allow it to restart on its own. All right, so let's take a look at some DEF producers now. So this one, it's coming up on the screen, is known as ventricular fibrillation. So ventricular fibrillation basically means that the ventricles in the heart are just quivering. They're not actually pumping. And so with this patient will not produce a pulse, is because there's nothing that the heart is producing a pulse is by pulsing. So there's no pulse with it. And so this patient will need emergent care very, very quickly. So one of the first things that we start is we start compressing the heart by doing CPR. The next thing that we do is we deliver a shock. And so when we do deliver a shock, what happens is, if you kind of think about it, is when your phone's acting up or whatever, you shut it off and you turn it back on, and hopefully it works. And that's basically what defibrillation does, is it shuts everything off, all the electrical activity in the heart, and allows the heart to restart. And this is ventricular fibrillation. Another rhythm that we can see is called ventricular tachycardia. So VTach, if you'll notice, it looks like a bunch of little M's all the way across the screen. Ventricular tachycardia may or may not produce a pulse with it. And again, if it does not produce a pulse, we immediately start CPR. We give medications, also in VFib, which is epinephrine, and we give a shock, trying to get the heart to restart on its own. Now we can have what's known as slow ventricular tachycardia, which looks a little like this. And so we can see the base of the heart, the base of the rhythm is very wide, and we see it across the ECG. And this ventricular tachycardia that we can see can also either have a pulse or not have a pulse. The next one is known as polymorphic ventricular tachycardia, also known by its more frequently used name, which is torsades. Torsades, or torsades de pointes, means twisting of the points. So take a look at the electrocardiogram in front of you. You see it go up, and it'll go down. It'll go up, and it'll go down. So torsades does not produce a pulse, or it can produce a pulse depending on what is going on. But the reason for this is because there's a magnesium deficiency, and so the treatment of choice for this is magnesium. A common rhythm that we see in a lot of elderly patients is this one, known as atrial fibrillation. So remember, we talked about ventricular fibrillation versus fibrillating, but we can also see this in the atria. This does produce a pulse, but what's cool is when you're checking for a pulse on a patient, you can actually feel that it's irregular. And so AFib is definitely irregular. And so one of the big things with this is these patients are at risk for developing blood clots because of the fibrillation, is because that blood becomes stagnant and it starts to build up, and we can see blood clots and everything. So a lot of these patients are on anticoagulant therapy, and so that's going to be important when you start talking about trauma and different things like that, is because if these patients are on anticoagulants, which is Xarelto is one of them, a common one is Coumadin, it actually thins their blood out, makes it less viscous, and makes it easier for it to go through without developing blood clots. AFib. Another, which is kind of a sister to AFib, is this little rhythm, which is known as A flutter. Now, A flutter is remember, AFib is irregular. A flutter is more of a regular rhythm. All right, but what's cool about it, if you'll look at the little pattern on there, it looks like a saw. Like this, the bottom, if you took a saw, like an old hand saw, and you turned it upside down and you saw the pattern on it, this is what it looks like. And a lot of these patients will have kind of palpitations, a fluttering of their heart and everything, and this is known as a flutter. Hopefully, if you do a good job in the medical field, we prevent this patient from being in this rhythm. And this is known as asystole, which means the cessation of all electrical activity in the heart. So asystole, we do try to treat that and get that patient into a shockable rhythm. We give medications such as epinephrine to get that heart back into a shockable rhythm. We perform CPR during this. But asystole is also one of the ways that we confirm death. So I want to show you a couple of conduction delays here really quickly. So if we talked about in the heart, and when we're looking at the heart, the normal pathway is it goes from the SA node down to the AV node to the bundle of His, and it separates off to the left and right bundle branches. And that's normally how your heart, that's the conduction pathway that the heart uses. Now, if there is an issue with that conduction pathway, we can see that on the electrical cardiogram. So the first one I want to show you is known as Mobitz type 1. Mobitz type 1. The PR interval, all right, which is a difference from the P wave to the QRS, gets wider, and then it drops a beat. This rhythm is also known as Winky-Bach. And so the way to remember that is wider, wider, Winky-Bach when it drops a beat. And this is Mobitz type 1. Mobitz type 2 is the following, also known as a classical heart block. This is where we have more P waves than QRSs. Now the next one is a complete disassociation between the conduction pathway between the atria and the ventricle. The atria are basically doing their own thing, and the ventricle is doing their own thing, and they're just not synced up together. And this is a very serious arrhythmia, which is known as third-degree AV block. And so you can see that the atria, which is the P waves, are doing their own thing, and the QRSs are doing their own thing, but they're just not together like they need to be. These patients will require something known as pacemaking. And so what we do is we put patches, these big patches on their chest, and what we can do is we can provide a tiny electrical jolt that takes over the pacemaking duties. And this is what's called the external pacemaking. So I hope this was a little bit informational for you. I know it's a lot to kind of take on, is because you may not understand EKGs and stuff yet, but at least you got to see a few of them and see why it's so important. Is because it tells us a whole lot about what's going on in the heart. Not only with the electrical activity, it can tell us a little bit about what's happening with your electrolytes, but we can also see things if a patient is having a heart attack, for example. We can see ST elevation, which is indicative of a patient who is having actual heart muscle damage. And we see this in a heart attack, and this is known as ST elevation. I'll go over that more later on. So I hope you're enjoying the videos and seeing all this cool stuff. I've got one more that I'm going to put out this week, which is all about congestive heart failure, CHF. We're going to talk about some different treatments for that. I hope you're enjoying the videos. Thank you so much. Thanks for watching, and I hope you're passing your class. Bye-bye.